the big focus now is on interception. So what is interception? Interception is the idea that you can sort of stop a cancer before it starts. And there's all sorts of analogies. The one that people talk about is weeding the garden, like taking out the bad cells before they have a chance to develop into cancer. And so a lot of the focus is trying to understand whether or not there are different therapies that could potentially help there. We've collected a lot of healthy breasts from BRCA1 and 2 mutation carriers at the Vassar Center because we're interested, and we work with them and with the Gray Foundation on doing what's called a pre-cancer atlas. And the idea is to really try to understand sort of what's happening, as I said, before cancer starts, so that we can intercept changes. And that's a collaborative effort across several institutions.
Hello and welcome to Cure Talks. Today we are talking about the complexities of BRCA gene-related breast and ovarian cancers. I'm Shweta Mishra, and we have with us today Dr. Katherine Nathanson, PALB2 Professor for BRCA-Related Research and Deputy Director at the Abramson Cancer Center and Director of Genetics at Vassar Research Center at the University of Pennsylvania. Joining Dr. Nathanson on the panel is Heidi Floyd, who is a sought-after influencer with over 10 years of experience in healthcare advocacy and breast cancer nonprofit management. And she's also an international speaker and a published author. Welcome to Cure Talks, Dr. Nathanson and Heidi. It's a pleasure to have you here on the panel today.
Thank you. Thanks so much for having me. Looking forward to the discussion.
Thank you. So Dr. Nathanson, we know that there are a number of inherited mutated genes that can increase the likelihood of breast cancers. And the most well-known are the BRCA1 and 2. So I would request you to start by giving us a bit of a background on how BRCA1 and 2 genes are related to breast and ovarian cancers, and touch upon the mechanisms of how these cancers develop.
Sure. So BRCA1 and BRCA2, when mutated, are associated with increased risk of predominantly breast, ovarian, pancreatic, and prostate cancers. It's thought that the increased risk comes from the fact that they are associated with homologous repair deficiency or DNA damage repair, or repair. I'm trying to think of how to simply put it, but sort of repair of your DNA. And so when you have a mutation in BRCA1 or 2, everyone has 2 copies of the gene, but then you have 1 copy that's not functional, and you can survive fine and do totally fine with just 1 copy that's functional on your cells. But if a second copy is lost, then that loss of both copies in the same cell can predispose to cancer. We know that women who have an increased risk, have BRCA1 and 2 mutations, have an increased risk of breast and ovarian cancer. There have been studies, both family-based studies and more recently sort of population-based studies, that have really looked at that increased risk. And again, depending on the study, the risk ratio obviously varies, although we like to look at the sort of population-based risk and sort of think about it as more as a probably 50%, 60% sort of lifetime risk. Again, there's a range of risk that's for breast cancer. It's lower for the other cancer types. We actually, interestingly enough, don't know why it's breast and ovarian cancer specifically. So what's called tissue tropism. Why is is it specifically mutations in those particular tissues that are associated with cancer is not really well understood to this day. Patients, particularly with BRCA2 mutations, can get a variety of other cancers as well, but many of them have a sort of somewhat increased risk of the population, but not to the degree of breast and ovarian cancer. But we haven't really quite figured out why that risk is particularly higher in those tissues, but we certainly know with many, many people and many, many large epidemiological studies that it's the case.
Mm-hmm. Thank you for sharing that, Doctor. And could you talk a bit more about the inheritance of these defective and harmful BRCA genes, so we can understand who is at risk of having these faulty
Right.
genes,
So,
and
I mean,
who should get
the
tested?
inheritance is what we call autosomal dominant. So if you have a parent who carries one of these genes, then you're at 50% risk of inheriting the gene. And that 50% is independent for each child. So it's like flipping a coin for each child. And having done this for a while, I've seen families with 4 people, no one gets a mutation. 4 people, 4 children, everyone gets the mutation. It's really a random flip of the coin. And so that's, again, the inheritance. We know that the mutations themselves are really more frequent in certain populations. There are some founder effects. For example, the West known or the Ashkenazi Jewish population with about 1 in 40 individuals who carry a mutation in either BRCA1 and BRCA2, probably because they went through what's called a population bottleneck. That is, their population got smaller, there's only a few founders, and then that number of population expanded, and so that was true. But the Ashkenazi Jews are by far not the only population. There are other populations that have an increased rate just based on sort of founder effects. That's true for other mutations in other genes besides BRCA1 and 2, but we're just specifically talking about BRCA1 and 2 as well.
Right, right. Thank you. Thank you for sharing that in an understandable way, Doctor. You did mention that these cancers, which are related to BRCA, have a high rate of recurrence, and you, in your research, have discovered factors that make breast and ovarian cancers associated with BRCA1 and 2 mutations more likely to recur, right? So could you please break it down for us in more simpler terms? Yeah.
Right. So there's a lot of different research, not just done by me, looking and trying to understand sort of recurrence and resistance. So this is true generally in cancers, particularly when we treat patients with targeted therapy. We want to understand why cancers recur or resistant to therapy. There's some sort of general paradigms around that, and so many times when you look at resistance to therapy, the mutation that causes resistance, and this is true again, happens in the same gene in which the mutation is associated with the disease or the disease susceptibility. So even what we call somatic. So for example, in things like BRAF, which is associated with melanoma, the resistance to some of those drugs happen again in BRAF. In BRCA1 and 2, probably the best or most well elucidated variants are what we call reversion mutations. So the idea is that you actually take a BRCA1 and 2 a mutant cancer, you treat it with something called a PARP inhibitor, which helps to work together. It's called with the function of loss of function. So let me just take a digression here. So BRCA1 and 2 is associated with homologous recombination deficiency. And when you have deficiency in the cancers and you lose function of homologous recombination, your the cancers become dependent on other forms of DNA damage repair. And so what they come out is the drugs come in and they hit those forms of DNA damage repair. So you have multiple sort of hits and affecting the cancer and causing regression because they can't repair their DNA and they can't you treat the cancer by doing that. So what happens then is that the cancers, I mean, I say they're smart, but I don't know if that's, anthropomorphizing cancer is not really where we're going here. But nonetheless, what they do is they try to sort of reintroduce the function of the BRCA genes because that's, again, where it's targeted. So those are called reversion mutations. And so those mutations go in and they sort of come in and they basically help to take out the mutant piece of DNA and where the mutation is, usually right around where the mutation is, they sort of chop that part out and then it reports sometimes a partial functionality, but functionality of the gene. And so that's called a reversion mutation. So that's one of the more well-known and well-documented mechanisms of resistance. Our studies actually, we went to look at sort of beyond in reversion mutations, that's with PARP inhibitors and sometimes with other kinds of DNA damaging agents. We went to look, but many people get treated with standard of care therapy rather than just with PARP inhibitors. And so we went to look at some of the reversion mechanisms there. So we identified sort of 3 possible reversion mutations. And one of the things that I think we had actually originally well documented, it was one of these things where we put some paper and a data, and people were like, oh no, but like, I have to say, I've never been told I was brave to publish something before, but that was the data, and it's been subsequently, subsequently validated in a lot of other studies. But essentially, as I mentioned, like in the tumors, you lose both the genes, but that's called loss of heterozygosity. But sometimes you see tumors where only one of the gene is lost. So the mutant allele is there, and then the other wild type layer is there. And what we had shown previously was that those tumors are actually resistant to many of the DNA damaging therapies, not surprisingly. So if loss of heterozygosity or biallelic inactivation is not present, those tumors actually don't respond to the agents that are developed to target it, not surprisingly. But that hadn't been as sort of well recognized that first of all, there are a percentage of tumors in patients with germline BRCA1 and 2 mutations that didn't have loss of heterozygosity and didn't respond. So what we found is that some of the tumors go back and forth between this state of loss of heterozygosity and non-loss of heterozygosity in a way to develop resistance, actually. And that was relatively new. We also found that there were actually different splice variants. So all of the genes in the genome, they're not just have one version coming out of mRNA. There's multiple different versions of the mRNA. And so we found that resistance favored certain versions of the RNA, which probably are more stable and more likely to go to make more of the BRCA1 and 2, especially BRCA2 protein. And then we also found that, not surprisingly, again, you're looking where you're treating is where you see resistance, right? Mm-hmm. So the other thing is we found that some of the tumors had very high level of the PARP1 protein, which is targeted by PARP inhibitors, and those tumors tended to also be more likely to be resistant. So there's sort of different mechanisms on the protein, the mRNA, and different DNA levels, all of which are sort of in the same pathway, sort of trying to counteract resistance. Again, I think it's nice because although there are new mechanisms of resistance, they sort of all fall within the same pathway to be able to identify them. Mm-hmm. Right, I went on a while there. So
yeah, no, thank you for distilling such complex information for us, Doctor. So before I jump on to invite Heidi in the conversation, could you please touch upon a bit on the treatment modalities? What does all of this mean in terms of developing new treatments?
Right. So I think one of the big focus now is not on treatment, but on cancer interception. So that's something where the Vassar Center for BRCA, which is at Penn and really a amazing place to work, and a lot of investigators focused on work on BRCA1 and 2. That focuses, the big focus now is on interception. So what is interception? Interception is the idea that you can sort of stop a cancer before it starts. And there's all sorts of analogies. The one that people talk about is weeding the garden, like taking out the bad cells before they have a chance to develop into cancer. And so a lot of the focus is trying to understand whether or not there are different therapies that could potentially help there. So one of them that's being trialed, for example, or trying to understand is, could one give lower doses of PARP inhibitors for long, to treat people to try to reduce the cells? Dr. Susan Tomczak, who leads the Vassar Center, is doing a vaccine trial to see if there is a way to vaccinate healthy individuals to try to target some of the cells that are that may be abnormal, but you're still again trying to use the immune system to get rid of early cancers or early cancer cells. So our work on LOH has really shown the importance that you have to lose both alleles and that you treat tumors differently depending on what their molecular features are at the beginning. And now we're sort of going back to say what's happening in the normal tissues and what's happening in the pre-cancer to try to understand how we can move that on to interception therapy. And that's really the next step in what we're doing.
Right. Interesting. That sounds hopeful. And thanks for sharing all of that. And with that, I will now invite Heidi to the discussion. Heidi, please take it away.
Hello, thank you. Thank you, Doctor, very much for your help. I have a couple of questions just based on what you said. If you don't mind, they're kind of off script, but I really am curious to know. First, when you talked about the founders, the people that, you know, have really high percentage of BRCA1 and 2, and you mentioned one specific group, what are the names of other specific groups that are in that same, like the Ashkenazi Jewish people? Who else might
there's
we know?
actually like a French Canadian founder, for example. Pakistanis have a particular founder. There's some Eastern European founder mutations. So again, these doesn't matter what ethnic group you are. You know, you can have a founder mutation. And again, this is a phenomenon we're discussing in the context of BRCA1 and BRCA2, but this happens with any kind of genetic diseases.
Okay, that was kind of my point, that it's not just focused in one particular area. It's global, right? It could be, okay. And
it can, like we have one that I deal with. I do something called BHL, which is called Shuvash polycythemia. That's a founder on like one island. I think it's in the
wow, cool. Well, not cool, but you know what I mean, still fascinating.
Yeah.
Very good. Thank you. And there's you were talking about using not preventative, that's probably not the right word, but like healthy tissue, healthy women with healthy without this to try to prevent it. There's a healthy breast tissue bank at the University of Indiana, I think. Are you familiar with them? Have you worked with them? Yeah. Okay.
Yeah, so that we're actually focused very much. We've collected a lot of healthy breasts from BRCA1 and 2 mutation carriers at the Vassar Center because we're interested, and we work with them and with the Gray Foundation on doing what's called a pre-cancer atlas. And the idea is to really try to understand sort of what's happening, as I said, before cancer starts, so that we can intercept changes. And that's a collaborative effort across several institutions.
Yeah, I love that. And I think for someone like myself, who's a breast cancer patient and a fierce advocate, like, to me, that just represents hope. What you just said is like a glowing beacon for the future that we can all kind of march to. So I'm really, really happy with that. So going into my questions that I have kind of prepared for you, what advice would you give to young women who are faced with this genetic predisposition for other ovarian or breast, and other than the standard of, you know, eat right and exercise, what are your thoughts about things like preventative mastectomy or oophorectomy, both of which can have long-ranging effects, you know, lasting the rest of their lives?
Right. So I think that's a great question, and a really complicated question. So I think, first of all, it's important to recognize we're talking about BRCA1 and 2 as sort of the high-risk breast and ovarian cancer genes in which mutations are, but there are a number of other genes in which you see risk. So we call them sort of, I would put PALB2 and sort of high to moderate, and then moderate penetrance genes, sort of CHEK2 and ATM. And so the answers really vary depending on which mutation which mutation a patient has. So I just want to say, like, it's not one size fits all when you ask those questions about risk. There's other genes that are rare, RAD51C, RAD51D. And things like that. So what I say to people is, I think that it's really important to understand the risk. I think it's really important to talk to people who do this and are experienced in doing this and have done this, seen many patients, really understand risk. Risk is an incredibly hard concept for people. And I think that that's something that is really having someone who's well-informed. I think that, individual decisions about things like mastectomy and oophorectomy, those are decisions that are made in concert with your physician. There's no one right choice for any one person. So I think that it's really important to have those decisions. I can say that for breast cancer, sort of the universal truth is, not universal truth, I say, universal guidelines suggest that, screening is good. We have good screening for breast cancer. We have MRIs. We have that. And so that's a discussion that is had with people. For ovarian cancer, our screening is not as good. And so I think, so the recommendations really are for prophylactic oophorectomy for high risk, again, for BRCA1 and 2. And those recommendations, though, the age varies based on BRCA1 versus BRCA2, slightly later for BRCA2. And there's also some trials that people might be interested. For example, the WISP trial, where they do prophylactic removal of the fallopian tubes, follow people, because we know ovarian cancer comes from the fallopian tubes, and then might do ovarian cancer removal. Some people may have, when they have their tubes tied, have their fallopian tubes removed, for example, and then go later on to prophylactic oophorectomy. So I think, again, there's sort of a lot of different options that really should be decided on concert with physicians.
Good. Excellent. Thank you. Can you talk a little bit more about the PALB2 that you just mentioned? Because
PALB2?
I'm sorry, PALB2. So tell me, like, as just a person, just a layman, I'm just a breast cancer patient out here talking to a million other breast cancer patients. How can we keep up with everything that you guys are working on? Where's a good repository? What can you do?
So for BRCA1 and 2, the Vassar Center really maintains a very active website where they really put in all the most recent trials, all the most recent information. All of that kind of stuff is really centralized at the vassar.org, which is our website. Really, it's meant to be a one-stop shop for people with BRCA1 and 2 mutations. Obviously, FORCE, which not obviously, but FORCE is an organization and a support organization that people use to get information that I think is really, that's very important. So PALB2, for those people who aren't as familiar, PALB2 is a gene that's called PAL of BRCA2 or PALB2. And it's associated with a risk that's about, depends, but basically about 30% lifetime risk. So lower than BRCA1 and 2. Again, when you look at it, you start sort of mammography and breast MRI age 30, slightly later than BRCA1 and 2, but still important to screen. And then it has a lower risk of ovarian cancer than BRCA1 and 2. So again, that's more of a discussion about prophylactic oophorectomy in that setting. So again, I think it's really important to have these discussions in the context with your physician and their individual decisions.
Very good. Thank you. Some people, much like myself, we have breast or ovarian cancer and a long family history of that. But when we go to be tested for, any of the BRCA, anything, it turns out that we test negative, for any of the mutations. Now, how frequently should we go back and retest if we're concerned about things like generational, if we have children?
So I think that's a really interesting question. So my first answer is you should participate in research. That's really important. We're not stop looking at genes that are associated with breast cancer. One of my current projects, for example, is to look at sort of the non-coding regions around BRCA1 and 2. Maybe there are variants there that we currently don't test for that are associated with genes. So really important to participate in research. We haven't forgotten about you, that you're negative. That's where we're actively working, actually. Sure, I work on BRCA1 and 2, and we work on modifiers, and we work on all sorts of stuff with that, but we also really actively work on who's negative. In fact, most women are negative. I just want to point that out. When you get testing, most women are negative. And we really want to find answers for those women. That's really still a really important part of our research. I do research funded by we do Breast Cancer Research Foundation, by Cure BRCA, all of these people. A lot of that's focused on trying to find either new genes or new variants in the genes that we have. In terms of retesting, I think that's a really interesting question. But I would say, that's a knowledge thing. Right now, the genes that we do testing for breast cancer actually has remained fairly stable for the last at least 5 years, I would say. So people who have been tested, there's, if you are only tested for BRCA1 and 2, absolutely go back and you need to be retested. But if you were tested for BRCA1 and 2, ATM, CHEK2, and PALB2, and RAD51C and D, you're pretty much done, you know, and there's not new genes right now. I'm not saying there won't be new genes. I'm not saying there won't be new variants, but we've been pretty stable for a while. And so I think it's going to take a lot to sort of change that sort of stability. But I do agree, like, how do you know there are new genes that people are testing for? How do you know there are new valid genes? I mean, I think one of the things, I've been doing this, I'm old, I've been doing this for a long time. I've seen genes come and go, come and go. And so I think it's one of the things that I really like to do is like make sure something's sort of stable. Like, and their genes have been removed. We used to do NBN testing. It's been shown it's really not associated with an increased risk. It's off. It's not on all the panels anymore, right? And I can name other genes. That's sort of the most obvious one. And so I think that, you know, you sort of want to get to a period of stability where things have been done and gone for a long time. And for you, someone who's a survivor, it's slightly different. I think the big issue is for someone who's not unaffected, and how do you do screening? So there are lots and lots of models for breast cancer risk. So Tyler Cusick, Bodicea, Gale, all sorts of different models. So it's important for someone with a family history or some concern to have an evaluation and go through a model. If you have a more than 20% lifetime risk, then MRI would probably be recommended. So you need to sort of have that, go through the testing and have evaluation. That's slightly different than someone who's had breast cancer. But if you have a strong family history and you have, for example, and I'm making this up, I don't know anything about her history, just to say that. Sister, for example, that hasn't had cancer, sort of to have that sister have her sort of modeling done to understand what her lifetime risk is, to be able to go for screening is important to do.
Okay, thank you. And there are two really important things that I think I picked up on what you just said, and I'm really grateful. First, if you are a breast cancer survivor, you are still needed in things like clinical trials, would you say, though, or research? Okay, and again, going back to your website.
Should say, actually, I realize I should say, if you're a breast cancer survivor, is they just changed the guidelines about genetic testing. I don't know if people have been, it's not been really well publicized.
Okay.
But it's the new guidelines from ASCO just came out in the last month that suggest all women with breast cancer under 65 should get genetic testing. And the NCCN guidelines are likely to follow the ASCO guidelines. And so that's actually just changed. It's not the genes have changed. The who gets testing has just changed, actually. And so I think that opens up testing for a lot of people who are survivors. Actually, that's a whole important point. I realize I digressed, but I just wanted to make
that's good.
And it's actually interesting. We were just talking about it like on an email chain. I don't know. There hasn't gotten a lot of publicity, which is kind of surprising to us. You would have thought it would have been sort of picked up, but that was recently published in JCO.
Well, I'll put it out there to the cancer community, my friend. I will make sure we
actually, it's in JCO, is recently in there, and it really wasn't like Mark Robson, I think, was the senior author on the ASCO guidelines there, and there wasn't actually a lot of it's been surprising, not a lot of discussion about that. And I think it ends up a lot of discussion of who's going to do that testing. We could have a whole another discussion, whole nother hour about that question.
Where if we are breast cancer patients and we do want to help participate in things like that, we just go to your website for like clinical trial information, how we can jump in. Okay.
Yeah, and so and we're always collecting so Vassar.org is a great website, and we are always collecting people who are at high risk for research. That's something we're very interested in. Yeah.
Okay. And for my fellow patients, if you have been diagnosed more than 5 or 6 years ago, consider getting retested, because they have made advances on.
Even 5 or 6 years ago, they were doing the testing for those genes. It just depends on the lab, and it depends on who got tested. The retesting is like, if you just had BRCA1 and 2, which is sort of where people, you need to be retested. But if you had all those other genes, no, not at this point.
Okay, excellent. Well, thank you very much. I really appreciate it. This has been fantastic.
No problem. Happy to help. Happy to do it anytime.
Thank you, Heidi. Thank you, Dr. Nathanson. Quite an insightful conversation. With that, it's time to wrap up the show today. Dr. Nathanson, thank you for sharing all your expertise with us in this very informative session. Heidi, thanks for guiding the panel with your insights. We also thank the University of Pennsylvania, and we will make this talk available on QTalks.com soon. So until next time, thank you everyone and have a great day.